He is standing in his kitchen early in the morning. The light is on, the floor is clean. He reaches for a cup and pauses, not because of pain, but because the room feels briefly misaligned. He blinks and continues. Later that day, he walks into a clinic for a routine appointment. His chart shows no emergencies. His vital signs are stable. He walks without assistance. The visit is unremarkable. At home, he tells his family that he feels stiff. He says his neck feels tight. He says he has been tripping more than usual. No one is alarmed. He is no older than expected. He has no history of stroke. He has not been injured. The explanation settles on age, posture, fatigue. The body is assumed to be intact. Weeks pass. He begins to fall. Not dramatic falls. Short, sudden collapses straight down. No dizziness precedes them. No warning arrives. He does not reach out to break the fall. His arms remain at his sides. He stands back up without complaint. The reassurance persists. This is not stress. This is not anxiety. This is not deconditioning. This is not an ordinary disorder of movement. What is unfolding does not arise from mood, behavior, or effort. It is rare. It is specific. It is structural. Self-diagnosis is not possible because the damage begins long before language can describe it. The first sign that something is fundamentally wrong appears in his eyes. He does not notice it at first. Others do. When someone speaks to him, his gaze seems fixed. He turns his head instead of his eyes. When he tries to look down, nothing happens. The eyes remain locked forward, as if anchored in place. Reading becomes difficult. Stares become hazardous. He misjudges distance not because his vision is blurred, but because the command to shift gaze no longer reaches the muscles that execute it. The world has not changed. The brain's control of orientation has. Inside the midbrain, specialized nuclei coordinate vertical eye movement. These structures do not think. They do not decide. They execute. They translate intention into motion with speed and precision. In this condition, those nuclei are degenerating. Neurons are disappearing. The pathways that allow the eyes to scan the environment are being dismantled. The loss is selective. Horizontal movement may remain intact while vertical movement fails. Looking up becomes slow. Looking down becomes impossible. Blinking becomes infrequent. The face adopts a fixed expression not because of emotion, but because the muscles no longer receive timely instruction. The disease does not stop at the eyes. It spreads silently through the brainstem and basal ganglia. These regions regulate posture, balance, and the automatic adjustments that keep a person upright. As the neurons die, reflexes vanish. The body loses its ability to correct itself. He falls more often now, always backward. The falls are abrupt. Protective responses do not activate. The brain no longer anticipates gravity. Each fall is a reminder that the internal map of the body has been erased. Speech changes, words become slow, the voice flattens, the muscles of the mouth and throat stiffen. Swallowing requires effort. Food collects where it should pass through. Aspiration becomes a risk not because of weakness, but because coordination has failed. This is not Parkinson's disease. It does not respond to the same medications. Dopamine replacement does not restore function. The pathology is different. The damage is deeper. The neurons that are dying are not merely deprived of neurotransmitters. They are structurally collapsing. Under the microscope, abnormal tau protein accumulates inside neurons. It forms tangles that disrupt cellular transport. The neuron cannot move materials from one end to the other. Energy production falters. Waste accumulates. The cell suffocates from within. These tau deposits do not remain confined. They propagate through connected networks. The brain's architecture is dismantled node by node. There is no inflammation to signal alarm. There is no pain to demand attention. The progression is quiet. As months pass, rigidity increases. The neck extends backward, fixed in an unnatural posture. The trunk stiffens. Walking becomes a sequence of deliberate, unsafe steps. Turning requires multiple attempts. Initiation of movement is delayed, not because of hesitation, but because the command must travel through damaged circuits. Cognition begins to change, not memory at first, judgment, flexibility, the ability to shift attention. He becomes impulsive or apathetic. Emotional responses flatten, the personality narrows. This is not depression, it is frontal lobe involvement. The systems that regulate behavior are eroding. Language comprehension remains intact longer than expression. He understands what is said. He cannot respond with the same clarity. The disconnect grows. Awareness is preserved while execution fails. The mind remains present inside a body that no longer obeys. Compensation attempts emerge. He learns to move his head instead of his eyes. He braces himself against walls. He widens his stance. These strategies work briefly. They are not adaptations. They are temporary substitutions. The disease continues beneath them. Eventually, even compensation fails. The neck can no longer turn freely. The trunk cannot adjust. The falls increase. Injuries accumulate. Independence disappears. He requires constant supervision not because of confusion, but because the brain has lost the ability to maintain posture and orientation. Swallowing becomes unsafe. Nutrition declines. Speech becomes nearly unintelligible. Facial expression is mask-like. Blinking is rare. Tears do not spread across the eye. The gaze is fixed forward, unblinking, unable to look down at the floor or up at the sky. This is the point of no return. The neurons responsible for eye movement, balance, and executive control are gone. They will not regenerate. The tau pathology has reached critical mass. The brain has lost entire systems, not functions that can be retrained. He is still alive. He is still conscious. But agency is gone. He cannot direct his body through space. He cannot meet another person's eyes. He cannot adjust his posture without assistance. The mechanisms that allowed him to interact with the world have been dismantled. The body becomes rigid and immobile. Communication is minimal. The internal experience persists longer than the external expression. The self remains trapped behind a fixed gaze, unable to signal, unable to move, unable to orient. Death does not arrive first. Loss of self does. The brain that once coordinated movement, attention, and presence has been reduced to fragments. What remains is awareness without control. This disease does not end with pain. It ends with erasure. The world continues to exist, but the ability to engage with it has been biologically removed. The eyes remain open, but they can no longer look. The body remains upright, but it can no longer move. The self disappears before the body follows. This is pathology of fear. And this fear is real, because sometimes the most devastating outcome is not death, but remaining conscious while the brain loses the ability to orient, move, and engage with the world.